Yeah, no, it's a very good start. And discussing boundaries when you are a lung specialist, it's a unique opportunity to reinforce the fact that we breathe from the very first time of our life when we come to Earth to the very end of our life. And the breathing is a unique event in our life. We don't feel it, but we do it regularly. And the lung is really the interface between our body and the external world, where we catch the oxygen, which will help us living. So at the end of the day, this interface is necessary because we need to extract oxygen from the environment. And on the other hand, it's a weakness because it is always exposed to the environment. Any insult will result in possible damage and some risks to the body. But it is a unique interface. It is very well designed. We will discuss that today. And it is full of resources. No, that's a good point. I mean, we live in Europe. We have differences between the countries. And of course, health is a national priority, and it may be different in one country or the other. However, there are some European priorities as well. And my own priority, rare respiratory disease, it is supported by the European Commission. That being said, your question relates to differences between countries. And indeed, in some countries, lung disease is a very, very strong priority. For example, you have in some countries national asthma campaign to prevent, treat, and manage asthmatic patients as well as possible throughout the country. In other countries, you have lung cancer screening programs where you try to find cancer as early as possible. In other countries, and in most countries, you have smoking cessation programs. You have also actions against air pollution. You have protection against respiratory viruses, and it has been very, very important recently. But if you go to every single country, you have different approaches. So it's not unique, it's diverse. And some countries are more committed than others, for sure. Very important comment. I mean, breaking walls, building bridges, that's my job. I mean, every day. And I'm very fortunate. I work in a very, very strong university, Paris-Saclay University, which is interdisciplinary by nature. And you mentioned very, very valuable disciplines, which are mandatory to develop novel treatment solutions for our patients. I'm not going to repeat them, but you can also enrich it. Mathematics, informatics, big data, imaging. So at the end of the day, one of my priorities as a researcher, very committed to lung science, but also as a dean of medicine working in a large community, it's to build multidisciplinary or interdisciplinary programs. And my university has therapeutic innovation as one of its priorities. And we work obviously with all the specialties you mentioned, and the chemists, the pharmacists, the medical doctors, of course, and all the people able to generate information and to find out from the very, very large amount of data what is the valuable information. That's really a very important point. And when we will discuss later about meaningful improvements we have obtained in recent years in my field, I mean, it comes from looking in a very large amount of data, the information which is disturbed in a rare condition, and then how to interfere with it. And you can interfere with the abnormal pathway with many, many options. You can use very simple drugs, very complex drugs, biologic drugs, surgery, etc. So at the end of the day, interdisciplinary is mandatory, but how to deal with data, it's one of my strong priorities. I mean, we have huge amount of data. More and more, we keep everything stored. And then we need people with a vision able to explore this data in the best possible ways. And we will discuss that further, I think, very soon. Breathing, it is life. Okay, that's the very clear information. From the first breath to the last breath, we breathe and breathe and breathe. And as you rightly say, many people don't care about it because they don't feel it. And they feel it when they exercise. They feel it when they feel short of breath for many reasons. But usually you don't think about it. And as we are human beings and we set priorities, usually breathing is not the number one priority. It's not visible. However, you feel it. And there is a very important feeling called dyspnea, disturbed breathing, uncomfortable breathing. That's like pain, but you don't know really what it is unless you experience it. With the recent COVID pandemics, many people have experienced disturbed breathing, dyspnea. And I think it was a unique opportunity to disseminate the message that healthy breathing is so valuable. I mean, it's like a gift. So when you are not sick, when you don't feel how important it is to breathe, I still think that you have to protect your healthy breathing. So first, you have to prevent the insults, smoking, etc. We will discuss that further. But clearly, protecting yourself from insults is not sufficient. You also have to breathe as well as possible. In some Asian communities, breathing is very important, and you can have also religious approaches of breathing. And it is, I think, important in your life to, of course, exercise. And when you exercise, you realize very, very fast that good coordination of breathing is essential. Then when you live on a daily basis, you need sometimes to take a deep breath just to relax a little bit. And sometimes also you have disturbed breathing because you have a condition or because there is unclear atmosphere around you. And you experience also that it has to be protected, your breathing. So my feeling is that exercising is one point, but also healthy breathing on a daily basis is important, and you can work on it. You can work on it, and we have physiotherapists. And when we were discussing multidisciplinarity, I mean, physiotherapy, it's an art, and some people need to be taught how to breathe normally. And after COVID, for example, I just give an example. Many people experiencing dyspnea, they after COVID, they had uncomfortable breathing for a while. And they were consulting in my department because they were feeling short of breath. And many of these people had what we call dysfunctional breathing. It's not a condition you can label very simply, but sometimes it is dysfunction of your vocal cord. Sometimes it is hyperventilation, because when you were sick, you had to hyperventilate and your body get accustomed to that. And then you have to be trained back to normal breathing. So I think breathing is so valuable that you have to think about it quite regularly. And if you experience dysfunctional breathing, you should see your doctor in order to see if there is a condition explaining that. Very important message here. So clearly you have to set priorities, but there are so many dangers, so many aggressions. I mean, the lung is certainly one of the most exposed organs of the body, and a very, very significant organ indeed. So I would mention smoking as one of the major priority. Of course, it's a very strong political message. I mean, smoking cessation it's political decision. You could ban smoking. I mean, it's always difficult to ban things like that, but you could also regulate it. And in Europe, I think the regulations are better and better. Access to tobacco is more and more difficult. We try to discourage early exposure to smoking. We try to make it less valuable. You know, the image of the cool smoker, etc. It's absolutely unacceptable. So I think there is a strong political message around smoking, but it's an obvious first part of my answer, but it should be the first part of my answer. Smoking is bad to the lungs, but also to the body, and even in the growing body in a pregnant woman. So it's bad, bad, bad. Then pollution, air pollution. I live in Paris. Air pollution is major. And we know for sure, and I work very close to the emergency department, that many, many people come with symptoms on the days of pollution peaks. And pollution should also be a priority. And it is a priority, but it takes time. I mean, you know, the fossil fuel engines are set to be banned in a few years for cars. There will be regulation for firms, plants, factories, but it takes time. And I'm afraid we do not have much time because pollution is really a threat. And a threat also, once again, to the weakest. We are still in a good situation, but the lung, I think at the end, maybe we'll summarize that, but the lung, I did decide to work on the lungs because it is an organ which is often affected in less privileged people. We will discuss less privileged areas of the world than in our countries. The lung has always been the target in the less privileged people working in poor conditions, etc. So when I mention pollution, you have, of course, atmospheric pollution, but you have also pollution at work and pollution at home. And the more you are deprived, the more you are exposed to these many, many damages. Then the bugs. With the COVID-19 pandemic, we have seen how frail we are. Even the strongest are frail. And when you get a pandemic like COVID-19, it is an eye-opener. I mean, we are all very weak in terms of protection against novel viruses. And it comes to your last question about climate change. Climate change, I mean, humans are marvelous, but they damage the treasure. And right now, we destroy the forest, we build large cities, we pollute, etc. The wild animals have to set themselves in our vicinity. And at the end of the day, you have bugs which come in our population, which should have stayed elsewhere. And clearly, there are many hypotheses, and I'm not going to develop all the hypotheses, but one of the hypotheses explaining why we have more and more bugs and more very large epidemics and pandemics, it's because of our way of living. We live in large communities, we live in polluted areas, less and less animal diversity, more and more difficulties for wild animals to stay where they should stay. So this is a very important point. And then humans have to be careful when they manipulate these bugs. And I'm not going to develop that more because it is a never-ending story. But clearly, when we play with fire, we have to remember that our lungs may burn. Yeah, definitively. First, the regulations I value so much are more difficult to implement in less developed countries. Smoking cessation, it's not the same deal in some countries versus Europe. Second, I mentioned the infectious diseases. Very major respiratory infectious diseases are still very, very prevalent, like tuberculosis. It is a priority for WHO. It is a priority for all of us. We know that if we don't consider it carefully, we will have multi-resistant tuberculosis strains, which may become a threat to the whole humanity. We know also that the HIV pandemic is not finished, and that many people in the weakest part of the world become infected still now, and then they got other infections and they need to be protected. So developing countries, it is our responsibility, our rich country priority to be supportive, to let them organize, of course, their policy, but be supportive. And there are some priorities, and many are respiratory priorities. I mentioned tuberculosis, smoking. If you travel to some very large cities in Africa or Asia, pollution is so important. So the weakest are my priority in my country and in the world. And the lungs are certainly one weak point of the chain of the body. And many patients will be sick because of respiratory diseases, and even respiratory diseases which were not that prevalent in developed countries, in developing countries, became prevalent because they used our Western way of life, and they developed some conditions like asthma, etc., which was less prevalent 50 years ago. No, it's a major priority. In Europe, let's say, in the Western world, we have seen an increase, a regular increase in allergic diseases as a whole, and in asthma. And asthma, it is a killer. I mean, that's something many people don't know, but if you don't treat it well, it is really a very dramatic condition, and even healthy people can die of what we call an asthma attack. So it's not because you are doing well most of the days that you are not exposed to a major event, and these major events can be a threat. So the number of asthmatics and allergic patients in Europe and in the Western world has raised markedly in the last 50 years. I mean, it is clear, it is obvious. And if you take the other countries in the world, in Asia, Latin America, Africa, there is a parallel increase. First, because of awareness, because of course we have to do our job and people have to know these conditions. These conditions are treatable. That's really important. They are treatment. This treatment should be affordable everywhere. And we have also different explanations. I think air pollution, smoking of the pregnant mothers, smoking of the environment of the pregnant mothers, Western way of life in housing, development of allergens in the population, diet is very important as well, maybe exposure to antibiotics also. There is this hypothesis, which is certainly true, that we have maybe a problem when we raise our kids in a too clean environment, and that being a little bit dirty is not bad for our immune system to develop. And this has been developed very, very nicely by some of my colleagues recently. And this Western world way of life, which is good, certainly for many reasons, has to be not excessive. And I would like to emphasize also that we have beautiful organizations in our countries. Our kids go to school very, very early, but you know, they catch all the bugs like the respiratory syncytial virus, RSV, flu, rhinovirus, etc. And they are certainly stimulated in terms of immunology. It can be good or bad, but building a good immunity is very important. COVID-19 has been an incredible experience to me, to all of us, I think, but to me as a respiratory doctor in the south part of Paris, with thousands of patients coming out of the sudden. I mean, they came, it was like a storm. it was really very important. So what I say is not very original, but we need to remember. I mean, now it's a few years after the COVID pandemic, people forget. I came by metro this morning to my hospital. I was the only one wearing a mask. We have to remember. We have to remember. And then your question is about, okay, COVID-19, it was an incredible threat to our model of life. I mean, our cities, our hospitals were under stress. I think it was also beautiful to see how we reacted as a community. I mean, we did very well. We did very well. Kudos to the people who developed the vaccines, but also the frontliners, the cleaners, the nurses, the frontliners in all aspects of the society, including the hospitals, but beyond. Then many people got COVID, and fortunately, most of them survived. We have to remember that. I mean, COVID-19 was not the plague. It killed a lot, and I'm very sorry for the people who died. It certainly killed nearly 20 million people right now. So it is a lot. But regularly, flu kills a lot of people. So we have to take advantage of this dramatic, terrible experience with COVID-19 to learn the lessons. So we have to prevent. And we have to be supportive of therapeutic innovation. The new vaccines have been built based on what we discussed a few minutes ago, new technologies, multidisciplinarity, mRNA understanding, mRNA vaccine, and also traditional vaccines, etc. Then many people survived after COVID, and many had what we call sequelae, long COVID. Okay, it is certainly a problem, but most people do well over time, and most of the people who got COVID build a strong immunity, and they may be infected again, but with less dramatic second infection. Then the people who we have seen in my department with persistent symptoms, there are different lung aspects. Dysfunctional breathing is the number one problem. And we published recently a good article on dysfunctional breathing, in which we analyze the many causes and how to deal with it, how to also perform physiotherapy and try to train the people back to healthy breathing. Then second problem in the very, very severe patients, it's some scars in the lungs. And these scars are usually not major, but some people have significant scars, and they should be seen in departments like my department. We set, let's say, a diagnosis, and we see what is the magnitude of the lung damage in these people. Very, very, very few people have been transplanted, lung transplanted because of damage, but it was mostly at the acute phase of what we call ARDS, acute respiratory distress syndrome. But now, over time, we don't have that many patients with that problem. So then you have the lungs and beyond. And in the lungs, you have the vessels. It's my specialty. And there were many, many pulmonary embolism at the early phase of the COVID-19. We have worked a lot on that. We know how to treat and how to prevent. Unfortunately, there was no major sequelae of the pulmonary embolism in our patients. And then you have the body as a whole. And many people developed symptoms affecting one organ or the other. There were some psychiatric sequelae. There were some cardiologic sequelae, not that many. There were some difficulties in the whole society to cope with the post-COVID period, with a lot of depression, mood disorder, lack of enthusiasm. And as a professor of medicine, I see many students. Many of them have been a little bit depressed after the COVID-19, and we have to be very careful with that. Suicidal thinking, etc., should be taken care of very, very carefully. And you have the many organs. I'm not going to develop all of them, but we are multidisciplinary in our hospitals, and we see all the patients who complain after their acute symptoms, and we see them with a multidisciplinary team, and we try to do our best to help them. It's always difficult to say that there was something good because people suffered. People suffered very much. I think there were more bad things and then good things. Many people lost very beloved parents, friends, colleagues, and many people had a hard time. And during the COVID-19, they were isolated, etc. That being said, and I'm very careful because my kids blame me when I say that, but there were some good lessons from the COVID-19. They blame me, but they understand. And when I say good lessons, we know how to work remotely first. And that's something incredible. I mean, 5 years ago, discussing remotely as if we were face-to-face was impossible. Second, we developed in that setting teleconsultation. So we can see the patients remotely. Of course, some people cannot do it, but many can. So that's another good thing. Third good thing, we have seen in difficult times that we are able as a society to be unified, united, and to fight a common enemy as a society. And I think, of course, it's over now, but it was good feeling to see that everybody was really committed to fight the COVID-19 threat. Then we know better and better, and I hope everybody has understood that we can prevent respiratory diseases with wearing a mask, doing vaccination, washing the hands, putting some fresh air in the room, trying to avoid being too close from sick people. I mean, very, very simple things. Not sending kids to school when they are sick. All these things are so obvious, but I think it was a good refresher. It was a good refresher. And I am a scientist, very, very committed to science, and that's my life. I would say the vaccine and the drug development has been unique. Drug development has been more difficult than the vaccine. Drug development, there were personalities who wanted to be in the lights, and that's bad. I mean, we are not here to be in the lights. We are here to serve. I always learn that to my students. We are here to serve. We should be humble. And telling, I know this treatment will work because I'm the best, that the worst start in science. I mean, you have to do it right. You have to do a randomized or at least controlled trial. And we have seen the community all over the world has been able to generate good information on drugs. And some very cheap drugs have been very valuable, like corticosteroids. So well done to the people who did that. But other drugs have been very valuable. I'm not going to mention them because it's not the place. Then the vaccine. The vaccine, what a fantastic, fast development of vaccines, but also with some lessons. When you develop a new instrument, you have to understand that the people are not ready. And some people have to be convinced, and you have to respect that. You have to respect that. I mean, we are not in a tyrannic country. I mean, it's democracy. On the other hand, you have to behave. I mean, you cannot expose your best friends and colleagues to a condition if it can be prevented thanks to vaccine. And then we realize that vaccine does not prevent totally the disease, but it prevents the severe forms of the disease. So at the end of the day, what is really important is also to protect the hospitals and to be not flooded with cases. So many good things. And the vaccines also, a very interesting thing I wanted to mention because it's part of my life also as a scientist. It's what I call pharmacovigilance. When you have a new baby on scene, you have to keep an eye on it. And, one of the vaccines induced some thrombosis in some populations, and it has been detected quite fast. And the warning came very fast, and the society knew how to adapt. I mean, this vaccine is not bad, but it has to be given with caution to some people. On the other hand, the mRNA vaccine, some people don't want to be exposed to mRNA vaccine. I try to explain. But if they don't want, we need other vaccines. And now we have plenty of vaccines. So that's a good thing. So maybe I've discussed enough that part, but you have realized that I have learned a lot during COVID-19. Thank you very much for focusing on that. During our conversation, we mentioned the weak and the poor and the people who are marginalized. And all my life, I've worked on rare diseases because they used to be called orphan diseases. And my fight is that orphan diseases become only rare disease. They are not orphan. They have people taking care of them. And the word orphan is important, of course, because it speaks to you. But rare is important also because it means that there are not many, but they are not often. I myself and many of my colleagues and politicians and patient association deal with this rare disease. So what is pulmonary hypertension? Pulmonary hypertension is very easy to explain. It's increased pressure in the pulmonary arteries. The big problem is that when you measure the pressure in the body, it's easy. You put it on the arm, you put the instrument on the arm, and you measure the pressure. The problem of the pulmonary arteries, they are in your chest. They are in the middle of your chest. So how do you measure the pressure if you cannot have access to it? And of course, a Nobel Prize winner has been able to develop instruments to what we call catheters. You put it in the vein and you can measure the pressure in the pulmonary artery and on the right side of the heart. You can define the normal values, you can define the abnormal values, and then other scientists have developed non-invasive ways to estimate the pressure by echocardiography. So at the end of the day, what is pulmonary hypertension? Pulmonary hypertension, it's pulmonary artery pressure mean above 20 millimeters of mercury, because the normal value is 14, the standard deviation is 3. And any value above the mean plus twice the standard deviation is abnormal. Then out of 100 people with pulmonary hypertension, only very few will have a rare form of pulmonary hypertension, because most of the people with elevated pressure in the pulmonary arteries, they have heart or lung disease, which are associated with elevated pressure, but it is usually not the major problem. It is more a marker of advanced heart or lung disease. However, in rare forms, genetic form, or forms related to persistent occlusion of the pulmonary arteries after pulmonary embolism, you have persistent elevation in pulmonary pressure because of a disease of the small pulmonary arteries. And these people, they have to be identified, they have to be seen by experts because they have a treatable form of pulmonary hypertension, and the community as a large of respiratory and cardiology and others has been able not only to define, but also to classify, to identify causes, genes, pathways which are dysfunctional, and at the end of the day, drugs and interventions. So in a word, pulmonary arterial hypertension, PAH, it affects around 15 to 50 people per million inhabitants. So it is rare, but it is not absent. There are several thousands of people with that condition in France. And our job is to identify them. And we have a rare disease program. So we build awareness programs. We build patient association support program. We educate the community of frontliners, GPs, students, etc. And we have identified centers of expertise throughout the country with a strong center of excellence in my department. So it is a political message. When you want to do it right in rare conditions, you need support, and you need a vision, you need scientists, you need doctors, and you need a community. I'm very, very proud of what has been achieved in my field, and we'll discuss it in more detail. But clearly, these rare forms are so important to identify. And what is the symptom? The problem, it goes back to the start of our discussion. It's dyspnea. You cannot breathe properly. And the people don't understand. They feel good, they are young, they are fit, and they go to their doctors, they say, I can't breathe. You know, this word is important, I can't breathe. And the doctors, they should be aware that if they eliminate the most common forms of dyspnea, like asthma, smoking-related lung disease, heart failure, anemia, etc., they need to think, well, and if it was a rare disease, and then try to orientate the patient with a specialist, and this specialist will be aware of how to cope with it and how to send the patient to the right place. So we have that for PAH. We have that also for chronic sequelae of pulmonary embolism. And what is beautiful for chronic sequelae of pulmonary embolism is that we can treat these people with a multimodal approach, with surgery, interventional therapy with balloons, and also with medical therapy. So we are very active. We are very active. And when we are given the opportunity to treat our patients well, I mean, we develop very innovative approaches. I will take two examples, one on group 1 PAH and one on group 4, chronic thromboembolic pulmonary hypertension. So in pulmonary arterial hypertension, many people in the 1990s and early 2000s, they understood better and better how the small pulmonary vessel were affected by the condition, and they understood that endothelial cell dysfunction was key in the maintenance of high pulmonary pressure in the pulmonary circulation. And some very important scientists, some of them you have interviewed, who got the Nobel Prize, have identified prostacyclin, nitric oxide, endothelin-1 as pathways which are disturbed in PAH. And then some companies have developed drugs interfering with these pathways. And these drugs have been tested in randomized controlled trials in expert centers. And in an incredible fast way, they have been sent from an ID from a basic scientist to a drug approved for a rare condition. So in the 1990s and early 2000s, we have understood how to treat the patient with what we call pulmonary vasodilators. But with these treatments, the median survival of our patient is between 5 and 7 years. So it's not enough. It's clearly not enough. The median age of my patient is around 55, and we have many, many pediatric and early life cases. So what we have done with my group and with European and international consortium, we have tried to understand how the disease develops in familial cases, because they are familial cases. And we have identified families, and we have detected the abnormal gene explaining the familial forms. And this abnormal gene is called BMPR2, and it is a member of the transforming growth factor beta superfamily. And this transforming growth factor beta superfamily is very important in the development of the pulmonary circulation. And of course, some people wanted to correct the BMPR2 defect, but some people tried to understand what was disturbed in the pathway when there was a BMPR2 mutation. And what they have found indeed that the BMPR2 works like a brake in a car. I mean, it stops proliferation of the small pulmonary vessel. And the small pulmonary vessels are occluded because the cells proliferate. So by stopping proliferation, they increase the accelerator. And the accelerator is the other side of the TGF beta superfamily at the pulmonary artery level. It's what we call the activin pathway. And the activin pathway indeed is not mutated, but it is dominant because of the mutation of the BMPR2. And recently, with many colleagues, we have developed an innovative method, which is for the first time in pulmonary arterial hypertension, a biologic therapy. It is a trap, a ligand trap, which will block activin. And by blocking activin, you block the increased acceleration of the proliferation of the small pulmonary vessels. And we have published 2 major articles in the New England Journal of Medicine, one in 2021 and one in 2023. And I was really delighted to be the first and the last author of these 2 articles. And clearly, we have set the scene for a possible real innovation in the field. So that was for PAH, maybe a bit long, but it's not that easy to explain. For chronic thromboembolic pulmonary hypertension, the small vessels are occluded by clots, which are fibrotic, and they remain in the vessel and they block the vessel. So surgery can clean it, but most patients cannot be operated because pulmonary arteries are like a tree and you cannot access every single artery. So around half of the people are operable, but half are not operable. And in the people who are not operable, we have developed multimodal approaches with medical therapies, pulmonary vasodilators, plus balloon pulmonary angioplasty. And we have published also a very important article in the Lancet Respiratory Medicine showing that it is very important not to oppose the different approaches, but to combine them. What we call multimodal approach, it's very close to your question on multidisciplinarity. I mean, we have different people acting for the best of the patient. So multimodal approaches is the way to go in PAH. Indeed, when it was orphan, it was dramatic because nobody could even think about developing something except if it was developed by chance. Now, politics is so important. I mean, I'm very enthusiastic and I try to share my enthusiasm because I'm completely convinced that all the rare conditions, not only the rare lung conditions, all the rare conditions can be understood and many can be treated. So my vision is that when you can't prevent, you have to treat. And when you treat, you have to treat early and with very, very devoted approaches which are based on refined understanding. So you need money for that. I mean, obviously, I am a servant of my university. I'm paid by my government, and that's it. But then if somebody wants to develop a drug, they have to invest, and it's not a small amount of money. So in the US and in Europe, there is the Orphan Drug Act, and clearly the companies which commit to develop drugs for rare diseases, they are supported. And when they develop a positive drug, and the drug is also protected for a while. So it is in fact attractive right now in the US and in Europe and in many other countries to develop what we call an orphan drug. I hate the word orphan. I like orphans, but I think these orphan drugs, maybe it's a good name. It means that they would be orphan if nobody cared about them, but they are endorsed by the new regulations. And if they are positive, they will be reimbursed at a good amount, and they will be protected for a while. In my field of lung and respiratory research, like in most of the fields, data is extremely important. And we are regularly exposed to very large databases. We fight a lot also to have these databases organized in a very good way with data which can be used by different people with different background. And if you want me to focus more on my field of excellence, which is pulmonary hypertension, I've been able with my colleagues to build the registries at national level. And for a condition affecting 15 to 50 people per million, we have a registry with complete data of 16,000 people. And that's an achievement. And these 16,000 people, of course, they give us information, and the politicians in my country support us a lot. And they want to know, so how many patients exist, and if we develop new solutions, how can they be treated? But then on top of that, big data, big clinical data, it's one thing, but we need also biobanks. And biobanks should be connected to the registry, and we need to have, with patient consent, of course, always with patient consent, we need to have samples. And not only the blood, but also DNA when it is acceptable. And also, when we do transplantation, I didn't mention that refractory patients are transplanted. We have the whole lungs, and it's a unique source of information. And then biology is one thing, but we have also imaging. And imaging, it's data. And these data, they are stored on big computers. And right now, I have a major research project which puts together clinicians with registries, biologists with biobanks, and radiologists with imaging banks. And I try to put them all together and make a nice soup, which will create innovative ideas and concepts to build new hypotheses and make our diseases even more treatable in the future. So big data, you need to be really in charge. I mean, you should not be passive. You need to have a vision, an idea, a direction, but you need to have the data stored, and then you should work on it with a multidisciplinary team.